button first. Okay. All right. Let's start with managed care. There are only, actually, before we start, I posted a study guide for weeks 2 and 3 on this week's in Canvas. So after all this is done and next week, I think that's going to be more of a detailed, focused study guide. Managed care terms. So first we have managed care. Basically, managed care is around to decrease healthcare costs, improve outcomes for groups of patients. Some are examples would be like HMO, which requires patients to choose a primary care provider and get referrals for specialists. Case management, which we're going to talk a good amount about. Coordination of patient care over time with other healthcare services, including social services. Involves planning, coordination, and monitoring care for patients in unique needs. Patient-focused care. It's delivery model that organizes healthcare around expressed physical and emotional needs of the patient. One example would be adjusting a hospital meal plan to accommodate cultural dietary preferences, or allowing the family to participate in care during end-of-life care. And differentiated practice, in which each nurse's educational preparation and skill sets are evaluated and determined how best to be used. A few more terms. Shared governance. This is a model to promote collaborative decision-making between nurses and administration. Case method, so total care. One nurse provides all care for the patient during the shift, and that's pretty standard. An example would be a hospital, or a nurse in a hospice setting provides physical, emotional, and spiritual support for terminally ill patients and their families. Or an ICU nurse manages ventilator care, medication administration, and patient advocacy. Functional method. Tasks are divided among staff based on their roles and expertise. One example is one nurse would administer medications while another manages wound dressing changes. Primary nursing, sort of the same thing. One nurse is responsible for overseeing the total care of a number of patients. And you'll see this in like a primary nurse oversees all aspects of care for a post-op surgical patient, including wound care, education, and follow-up. In the home health setting, a nurse is assigned to a cancer patient, coordinates chemotherapy appointments, pain management, and emotional support. Team nursing, you'll see pretty often. We have registered nurses. Example, RN manages complex assessment and care plans. LPN administering medications, and unlicensed assisted personnel or personnel would take care of hygiene needs and other tasks. Case management. Any questions on managed care before we go to case management? This is a very quick rundown on that. The case management describes a range of models for integrating healthcare services for individuals and groups. Most places have case management. Key responsibilities. One is assessing patients. For example, a nurse case manager visits patient recovering from a stroke to evaluate the safety of the home and identify particular needs. Coordinating and planning care. Case manager coordinates for a patient with diabetes, scheduling appointments with an endocrinologist, dietitian, and primary care provider. Another example, for a cancer patient, case manager organizes chemotherapy, imaging scans, and follow-up care while communicating with multiple specialists. Collaborating with other healthcare professionals, and they do this quite a bit. An example would be case manager collaborates with physical therapists, occupational therapists, and social workers to transition a spinal cord injury patient from hospital to a home, coordinating certain services like home health. And monitoring patients' progress, following up weekly with a heart failure patient to monitor symptoms, fluid intake, and adherence to prescription medications. Evaluating patient outcomes. One example would be reviewing readmission rates for COPD patients to measure the success of home-based interventions like oxygen therapy. Care management models. Similar to case management, but focuses on populations instead of individuals. An example would be managing care for a diabetic patient across the entire healthcare system to reduce hospitalizations and improve disease control. So they're sort of in the business of reducing cost for healthcare as well. A goal is to involve or ensuring seamless care transitions across different levels. Example would be hospital implements coordinated care for post-discharge COPD patients, linking home health services, pulmonary rehab, and telemonitoring. Concerns with health promotion, disease prevention, cost control, and use of other resources. And I'll just leave this one up here for a minute, but it also involves critical pathways. And this one happens to be about chest pain. Basically, these are standardized care plans used to manage predictable patient conditions and ensure consistent care delivery through those particular diseases. The nurse as a care manager or case manager. And oftentimes we'll see nurses as case managers, sometimes social workers. They coordinate all aspects of care. Nurse case manager ensures that the patient recovering from hip surgery has appointments with physical therapy, medication management, and follow-up visits scheduled seamlessly. Advocates for the patient throughout their journey. And plans strategies to address individual patient problems. An example would be creating a care plan addressing complex needs for diabetic patients, including nutritional counseling, medication adherence, and foot care. Roles vary. Patient care facilitation ensures timely discharge planning for hospitalized patients with pneumonia, arranging oxygen therapy and follow-up appointments. Interprofessional team collaboration, which is probably one of the bigger things. Collaborating with social workers, physical therapists, physicians to create a discharge plan for the patient needing rehab and home modifications. And outcome monitoring. Example would be tracking a heart failure patient, weight, med adherence, and symptoms to hopefully prevent readmission to the hospital. Some skills required: clinical decision-making and critical thinking. An example would be evaluating a patient with multiple comorbidities to decide priority interventions and prevent complications. Holistic patient assessments, where we focus on physical, emotional, and social environmental factors. Identify and address coordination challenges. Overcoming delays in care by ensuring transfer of updated medical records when transitioning to different facilities. And ensuring evidence-based guidelines are used. So using current clinical protocols for wound care in a diabetic patient would be an example. Care plan development. They're really good at this. Identifying actual and potential problems. So for a heart failure patient, identifying potential problems like fluid overload or medication non-adherence that could lead to readmission. So they want to address that relatively quickly. Addressing cultural, religious, or complementary care needs. So respecting the patient's religious beliefs by involving chaplain at the end of life care. Consider herbal medication preferences in care plan. Develop care plans with patient and caregiver input. An example would be collaborating with family members to create a nutritional activity plan or nutrition and activity plan for a recovering patient from surgery. And use plans as coordination framework. Coordination and communication. Initiate consultations and obtain necessary orders. An example would be a nurse case manager consults a dietitian about a malnutrition or malnourished patient. Update care plans as referral occur. Adding speech therapy to care plans after identifying communication deficits post-stroke. Maintain communication with patients, families, and teams. So regularly updating family members about the patient's rehab progress and expected outcomes. Monitor and revise care plans as needed. So when we get into different systems like pain, GI, cardiac, you'll see a lot of plan and then implement, then evaluate. So this kind of fits into that. Document care plans. Recording updates such as wound care healing is an example of that. Some case management key elements. Active involvement from the time of admission. So we want to get the case managers involved as early as possible. For a trauma patient admitted to the hospital, the case manager collaborates with the healthcare team from admission to identify discharge needs like rehab or any other services they might need. Identification of need for case management. Not every patient needs a case manager. Recognizing who might benefit from case management, mostly chronic illness patients, like complex medical conditions, frequent hospital admissions, and social barriers like lack of transportation or caregiver support. And elements for successful case management, like interdisciplinary collaboration, clear communication, and patient-centered approaches. Case study. So Mr. Jackson is a 62-year-old male with history of hypertension, type 2 diabetes, chronic kidney disease. Over the past 15 years, Mr. Jackson experienced frequent hospitalizations due to complications. He also suffers from depression, which has worsened since his diagnosis, making it difficult for him to adhere to his treatment plan. And okay, there's a question. What are Mr. Jackson's primary needs as identified in this case study? And I kind of flashed it on there already. And we'll start with Curry. What do you think?
That's with depression.
Yeah, deal with the depression. Yeah. And what do you guys think? Yeah, so managing the hypertension, diabetes, and kidney disease. So physical needs, preventing further hospitalizations as well. And then somebody mentioned depression. So we're gonna do some mental health help here, addressing depression through counseling or support. And adherence to a care plan. We want to make sure he's being compliant with his medications and treatments. How can the case management model assist Mr. Jackson in achieving better health outcomes? And think about what the case managers do. Good. Yeah, coordinating to make appointments with behavioral health and maybe other services. Good. Anything else? Patient goals. Okay, good. And anybody else have any thoughts? Education, that's big. So we have the team approach where we talk to other disciplines, address medical, mental health, and social needs, improve communication and care coordination, and goal setting. We didn't mention that. Couple of big goals would be health stabilization and depression management. And then somebody mentioned patient education as well, providing resources and teaching on med adherence, which is kind of big. A lot of people don't know what their medications are exactly for or what they're called. And symptom management. What specific goals should be set for Mr. Jackson to ensure effective case management? Curry, what do you think?
Maintaining a certain level for his hypertension and blood sugar.
Ooh, good. Good. What else? Mental health. Good. Okay. So some health goals would be to maintain blood pressure and hopefully a little bit lower than that, achieve controlled blood sugar levels, hemoglobin A1C of under 7%. That's just a kind of a long range on how they're controlling their blood sugars, and monitoring and slowing chronic kidney disease progression. And then we mentioned mental health issues. So scheduling regular counseling sessions and encouraging engagement and support groups. And then treatment adherence, develop a medication schedule and monitor adherence at follow-up visits. And all of these, we want to be at the patient's level of understanding and education. So we don't want to talk over their heads or talk over how they understand. We want to go on their level. And I didn't put a question on there apparently. Let's see. Actually, I think we're going to skip that and go to collaboration. Let's see. Time. Okay. So collaboration basically is two or more individuals working towards a common goal by combining skills, knowledge, and resources to while avoiding duplication of efforts. The ANA, or American Nurses Association, standard of professional nurse practice. This is their stance on this, and I'll just leave this up here for a minute. And after this section, we'll probably take a small break, even if it's early, because we have a good amount on the Cahoots game to cover. And I don't know how long that's going to take. All right, some concepts of collaboration. Interprofessional collaboration improves patient outcomes. So we want to be able to collaborate between nurses, physicians, therapists, and other healthcare team. An example would be a stroke patient benefits from coordinating efforts involving physical therapy, occupational therapy, and nursing to restore mobility and independence. Successful collaboration requires key skills like communication skills. The nurses use SBAR, situation background assessment recommendation, when handing off to patients or handing off patient information to physicians or other nurses. Teamwork and respect, valuing the expertise of respiratory therapists in managing ventilated ICU patients, and working to establish a climate of mutual respect. The nurses ensure input from all team members is considered when they're creating a care plan. The nurse as the collaborator. So with patients, we want to empower the patient, let them make decisions and enhance self-management skills. An example would be teaching a diabetic patient how to monitor blood glucose levels and adjust diet and activity accordingly. With peers, we want to share expertise and build trust, as we don't quite know everything, so that's why we want to collaborate with other team members. Nurses support each other by sharing knowledge, fostering trust, and providing feedback. An example would be a senior nurse mentor for a graduate nurse on critical care protocols and patient communication strategies. With other healthcare professionals, recognizing expertise, listening, and sharing. Collaborate with pharmacists to ensure safe medication reconciliation and patient education. With other professional nursing organizations, we can collaborate within those. Nurses working with the American Nurses Association to develop new policies for safer patient care. And with legislators advocating for policy change. Example would be speaking to legislators about importance of funding for rural healthcare access programs. Some concepts. Interprofessional collaboration improves patient outcomes. The nurse collaborates with the patient to involve them. And actually, that might be my same notes from the other slide. There we go. So effective teamwork reduces medical errors and improves patient safety. Developing skills in communication and teamwork. The nurse must use clear communication methods to ensure everyone on the care team understands what they're saying and understands their roles. Value roles, responsibility of other team members. Recognizing each member's expertise leads to better collaboration. An example would be consulting with a physical therapist for post-surgical patients, mobility goals. And then establishing a climate of mutual respect. I think we've already covered that. Hopefully I'm not going backwards. A little bit on conflict management. Interprofessional conflict occurs within the individual. So that's when we have stress and we're conflicting with ourselves. Interpersonal conflict is between two or more individuals. Intergroup conflict between teams that are in competition or opposition of one another. And interorganizational conflict, a conflict between two organizations existing in one market. And one more slide before we take a break. Some conflict topics, cause of conflict could be personal clashes, poor communication, or unclear expectations. An example would be a nurse feeling undermined when a colleague repeatedly dismisses their suggestions. Preventing conflict, address issues promptly, promote transparency, and avoid emotional responses. Conflict management styles, competing, collaborating, compromising, avoiding, and accommodation. Nurse leader uses collaborating style to resolve disagreements about patient care assignments. Responding to conflict, encourage honest and objective discussion. An example would be a mediator facilitates a dialogue between nurses and physicians who disagree over a treatment plan. And incivility in the workplace. That could be a whole lecture. Rude behavior can escalate to bullying and violence if unaddressed. An example would be a nurse experiences constant passive-aggressive comments from a colleague, creating a toxic environment. And there's a whole thing about this. I think that's what I did my master's degree capstone on. And it causes staff to think about that conflict and bullying as opposed to their caring for the patients. Kind of gets in the way. And that's it for that. Any questions before we take a little break? All right, so let's take like 10 to 15 minutes. And then we'll come back and talk a little bit more.
Do you want us to start a new Word document, or do you want us to work on the start text?
I think one for everyone. Yeah.
And you want to do Word or is Word document?
I think both would work.
Okay.
Yeah, I don't know what Google Docs looks like on Canvas, but you can give me that. Yeah,
Thank you.
no problem. Oh.
It's the same,
Hmm.
right? First one.
Oh, that is strange. Huh. Wonder why it
I'm
looks
gonna
like
look on the
that. Oh,
computer.
switch to light mode. Try that. Oh, well, okay, right, click on it, and then switch to light mode. There we go. Oh, that doesn't show anything, does it?
Mm-mm.
It's-
I'm gonna look on my computer. I don't know if it's just because on my phone or what.
And then switch to light mode again. I wonder if it just takes a minute to. There's not much on there, is there? Hmm.
I'm gonna look on my
Yeah,
thing.
yeah, let me see what it looks like on mine.
Looked really good. I was telling Faith, I think it was good because we already had an orientation, like, our first day wasn't one. Week, so we went and did all of our, epic training.
So you went up through that.
Yeah, on Tuesday. Yeah. I don't know, where should I?
I'm playing on my phone.
Some fun art finding. It went really good.
I know one of the things that created is.
Mhm.
3 weeks.
They had those sessions that everything was wrong, but like, we don't like on the board. So we got split up into like.
I might have an answer.
4. So one.
Since they're hybrid, this is- I don't have access to the whole work for them.
Mhm.
Is that person in the Canvas system? Or are we supposed to just go off
I
our-
think so.
Okay.
Yeah, if not, let me know.
Okay, I can.
And I can-
But maybe I was looking.
Okay.
And I'll double check when I go
Okay.
back to the office too,
Okay.
just to make sure.
Thank you.
No problem. Mhm.
Are we supposed to do a new, start a new one for this term
Yeah.
or keep on?
A new one.
New there, like I like how I can set up my. They call it your mind, they call it on the area. You just set up your patients and so. You can print out a paper on that and use it, so it was really nice. And nursing there, like the first, she graduated from SWOCC 2 years ago, she's been a nurse. It's full schedule. I'm gonna be taught that they're like a tripod.
Yeah, they have See, I always see like the flight crews always have them, but theirs are like just in-house, they're not like this.
So I ordered one yesterday.
Yeah,
I think we all have them. I have those. You do,
I think all these guys do too.
They do.
I don't, I need to go. Yeah, I think
I,
they.
mine came with 2, so I'll give you the other one. Yeah. Just like $10.
Oh, really?
That's nice. Comes with 2? Yeah, I know.
I got
Wow.
mine.
I was gonna give it to whoever wanted it.
That's cool. Yeah, I was like, oh, gosh.
Yeah, they're really nice. The one that I have is so bulky, big plastic one. I mean, it's good to keep like me. Cause she wants us to bring our check off with.
Yeah.
Not, but. I think I really-
Yeah.
And I like what I'm with all these.
Yeah, like all in. Yeah, everybody thought I told them like, I think when I was looking for just a folded half one, you know, so I was those. You know, something.
Well, then it's the top ones too.
Really?
Yeah.
Well, it's in your pockets, you leave it and then you write it.
Yeah,
Makes a lot of sense.
yeah.
It doesn't make sense that I can spend $50 on my kid, but I do. I do the same thing.
This one's only this.
I think I just spent $50 on a pair of shoes for my toddler. Oh my god. I mean, I'm like, I will not.
It makes it more difficult than make such cute stuff.
Well, okay, my daughter too is such a shoe girly, so we went to like, Grange Co-op up in Grants Pass, and she saw these cowboy boots, and she reached for them, I was like, okay, let's try them on. And then she walked around in them, and she showed daddy them, and it was.
Really, can't go back.
Yeah, and I was like, we don't have to get them, she'll totally forget about them, and I really.
Oh, Dad. Cute. That's cute. Girl stuff is just so much. Thank you. I was, when I had my girl, it was bad. Yeah, me too. I was so bad. My husband's like, Haley, you gotta stop. It's like I can't. And my stuff was expensive. And my boys will do too, but like it's all the same. You know. When my son came, I spoiled him in a different way. I don't know. I bought him a lot of stuff, but with my girls, it was out of control. Yeah. We're shoe addicts too, like all my kids. Yeah. Like, it's really bad, I know. And my kids' shoes are so. But my son, like, I don't mind paying a lot for his shoes, because he's so active in like all sports, and then he's just, so he goes through them quickly, well, not quickly, but I don't mind such a shoe. She's careless with her shoes. Like, no. That's how I was when I was younger. I just tear up my shoes so I can get new pair. Like stomping around in mud, like the first day you wear them. Oh no. Yeah. My youngest, she's 7, and she been wanting rain boots. So I bought her these cute little rain boots, and she's nonstop wearing them. Oh. She wore them to school today, even though it's not raining.
I know my daughter has like 2 pairs of rain boots. Yeah. And she's so cute. She's got a little white up one. Like every time she stops, her little feet. My son got out here. I have this like container of like all his old shoes, and he had some like and they were twinkle toe shoes, but they were like cars that movie cars, and and it still lit up. Oh, yeah, you should be still like that. They're so cute. How old is he? 15. I know. I was like, I can't believe they still work. Yeah, they're really tiny shoes. Cute.
And while you guys are finishing break, I'm gonna see if I can totally mess this up. That. Okay. So if you wanna put that in, and we'll do a little survey. Over and over and over. That too. All right. And Curry, can you see the screen okay?
Yeah.
Yeah.
Okay, good. Yeah, I was hoping I did it right and looks like I did. That's exciting. Yeah, and you can use fictional names if you want to. Just make them interesting. Wait a few minutes. So I put my the rest of the slides on Kahoots. So there'll be one, I'll kind of go over it. And then there should be like maybe 2 or 3 questions for almost each one. But there's a pretty good amount of them, so we'll see how far we can get. I posted
Oh,
Is it any?
Yes. PowerPoint, not counting the Kahoots on Canvas. And I think it has my notes and all that good stuff. And hopefully it takes a whole bunch of people. I have no idea what the limit is. And this is, you guys are my guinea pigs, so if this works, we'll do it again sometime.
Vote on the TV.
I like it's me, that's a good one. And I don't see any inappropriate ones, so that's good. Could be interesting. Yeah, we'll wait another like 3 minutes and then we'll get started. And some of the slides, you'll probably see me referring to some of my notes, I have them on paper. So I'll try to make it look like it's seamless. We'll see how that goes. Uh, 2 more minutes. It's a good way to be able to use your phone during lecture. All right, so we'll get started and we'll see how this goes. Okay, and I think people can still add while the game's going, but I'm not sure. We'll find out. All right, so, and hopefully this doesn't have time limit. So we're going to talk about groups first. Purpose of groups. Achieve goals unattainable by individuals. There are a lot of those. Combine diverse ideas and expert knowledge from different groups. Share information quickly and consistently. And they're good for taking calculated risks to innovate and improve on healthcare. An example would be the AACN team to develop guidelines to protect nurses during aerosol-generated procedures. And let's see. Functions of groups. We have a couple different ones that you should know. Primary group, support members and share experiences. Secondary groups, and then the next one will kind of fill this in a little bit, are to fulfill specific purposes like therapy, political actions. Key differences. Primary groups focus on emotional needs like family, nursing units, and close friends. And secondary groups are focusing on goals, so not as emotional. Group communication. So we talked a little bit about this. Primary groups are more emotional, and smaller groups like family members, providing emotional support and connection. Nursing team, especially if you're giving a report to another nurse. So that would be primary group. A secondary group or professional associations like the ANA. Committees. So hospice or hospital ethics committee would be one of them. Or a safety improvement committee. I think we have one more slide before we go to the question. The quiz, okay. All right, so what is the primary function of what is the primary function of the primary group in healthcare settings? And you have 4 choices here. Hopefully you can see that with my shadow not in the way.
Yeah.
So does it must have a time limit? Okay. Provide emotional support to members. Good.
I know, I.
All right. So next time I'll set it to like 30 seconds, maybe 40. All right. So next one. Heather's ahead. Okay. All right. A therapy group is an example of which type of group?
Thank you.
Well, we have a bunch of answers. Good. Secondary group. Good. So we got 9 people that answered that one right. And remember, therapy groups really don't have a lot of emotion attached to it, or personality or personal stuff. Good. All right. Heather's now in 3rd place, 4th place. Okay. All right, so levels of group formality. So we have a formal group, semi-formal, informational or informal groups, and visual aids. Actually, that's part of informal groups. Formal group has authority imposed from above, so you'll want to remember this. Rigid goals, structured norms, so a lot more structure. Semi-formal groups have selective membership, structured activities, and some prestige. Informal groups governed by unwritten rules. They're a lot more flexible in roles, spontaneous interactions. And I'm not sure what that bottom thing is. Characteristics of effective groups. One is cohesiveness, sense of belonging and support for all of the members involved. Communication should be open, two-way sharing of ideas and feelings. Decision-making, consensus-based is ideal, inclusive and flexible. So there's really no dumb suggestions, I guess I would say. Well, maybe there is, but in a group setting, there shouldn't be, but you'll discuss that and weed those out. Conflict tolerance, resolving disagreements constructively. And I think I just accidentally put the visual aids without the actual visual aids, so we'll skip that. All right, quiz time. Which of the following is a characteristic of a formal group or of formal groups? Right. A lot of people got that one right. Right. Yeah. Heather's now in second place. Went from 1 to 4 to second. Okay. And BG is ahead so far. Right. Another question. Which statement best describes informal groups? All right. Almost everybody got that one right. Good. Members voluntarily create flexible, spontaneous interactions. Okay, so BG is head. Another question. What is the hallmark of effective group communication? All right. So most everybody got it right. Open two-way sharing of ideas and feelings. Okay, Heather's ahead again. Another question. A group demonstrates ineffective communication when? All right, almost everybody got that right. Okay. And remember, it's effective communication when members discuss feelings about the group's operation. The right answer. Leader enforces closed one-way communication. One thing you don't want to do. All right, so far so good. Group dynamics. 5 characteristics of group dynamics. Commitment. That's about shared goals and support. Decision-making ability, engaging all members for sound decisions. Member behavior, roles like information giver. So that's the person that's given information, the seeker, the person that's listening, and the facilitator. So whoever's in charge of facilitating a group. Cohesiveness, and we saw that earlier. Strong attachment and shared purpose. Power, shared influence to encourage collaboration. A nurse is facilitating a group discussion. Which behavior best demonstrates the role of the facilitator? All right, almost everybody got that one right. Yeah, so the primary role of the facilitator is to maintain focus and clarifying ideas among group members. Let's see where we're at now. Heather's still ahead. And Angel is on the board. Right. A nursing team is meaning to improve unit policies. Which characteristic indicates a high level of cohesiveness? Making notes for the next Cahoots. Longer time. All right. Members share a strong sense of purpose and mutual support. Good. Lupita is coming up. Right. That's tools for effective decision making. So there are a few things. Brainstorming, where everybody kind of comes up with some ideas and throws out those ideas. So generating many options quickly. A decision tree, visualizing choices and outcomes. Scenario planning, exploring what if scenarios or situations. Worst case scenarios. Evaluating risks to choose the best alternative. So having a set of alternatives or ideas and doing kind of a risk assessment on those. Some challenges in the groups, monopolizing, where one member kind of dominates the discussion. Groupthink, and you'll want to know this one too. Pressure to conform and avoid critical analysis. So basically agreeing with everything that the group says. And nobody speaks up. Scapegoating, blaming one person for group failures. Silence and apathy. Basically, it's a lack of interest and engagement. And transference and countertransference, misplacing emotions affecting the group interactions. A nursing team uses brainstorming to ID solutions to reduce patient falls. What is the primary advantage of this technique? It ensures consensus before implementing changes. All right, so we're pretty split there. Helps identify risk for each potential solution. Let's see. Fosters creativity by generating many ideas quickly. So that one is the right answer. And you'll notice in NCLEX questions, there's always like a couple of right answers, but there's one that's usually more right. And I have a meme about that in one of our lectures coming up. A nurse suggests using the decision tree to address staffing shortages. What is the purpose of this technique? To visualize choices, outcomes, and consequences. Is my head in the way? Okay. Hey, and that is the right answer. Okay. All right. We're getting up there. A nursing team experiences groupthink. Which findings support this term? You see the yellow down? All right, members avoid disagreements to maintain harmony. I mean, harmony is a good thing, but not in groups. All right. And Heather still maintains the lead. And apparently Hannah has 9 correct answers in a row. That's pretty cool that it keeps score like that. A nurse notices that one group member dominates the discussion in the group in the meetings. What is the best way to address this behavior? You guys see that? Or am I in the way? Oh. And the yellow is confront the member in front of the group. 27. Interrupt supportively and redirect the discussion. Good. And I like that nobody answered, ignore the behavior and avoid conflict. All right. Okay, Heather lost her lead. Strategies to overcome challenges. Promoting effective group functioning. So we want to, and I probably should have done that quiz after this one, but oops. Addressing monopolizing, interrupting supportively, and reflect behavior. And did I mention this is my first time doing this one? So, but you guys did great on the quiz. Preventing groupthink, encourage critical analysis and diverse opinions. Avoid scapegoating, promote accountability and professionalism. Increase engagement, recognizing and addressing disengagement early and not towards the end of the group. Managing emotions, be aware of transference and countertransference. Safety and patient outcomes. Why does effective groups matter in healthcare? There are a few reasons. Ensures patient safety. That's the biggest thing. Patient safety is number one. Preventing medication errors and improves care coordination. Poor group dynamics can harm patient outcomes. And quiz time. During a meeting, a group member dominates the conversation. What is the best action for the nurse to take? How's that? And the yellow is ignore the monopolizing behavior entirely. All right, supportively interrupt and refocus the discussion. It seems like we did that one. Oh, well, I guess we did it again. I think I just forgot to erase that last one. I was going for repetitiveness, that's it. Okay. A nurse wants to prevent groupthink during a team discussion. And did we just do this one too? Okay. What strategy should the nurse use? Yellow is avoid open discussion to save time. All right, almost everybody got it right. Promote critical analysis and diverse perspectives. Racking up the points. Of course, there are a whole bunch of them. Why is effective communication among healthcare teams essential for patient care or safety? And the yellow is it reduces the time needed to make decisions. All right. It prevents medication errors and improves care coordination. Good. Oh, Gordon Ramsay is making a comeback. Yay. Not on the board yet, though. What is a possible outcome if healthcare teams have poor group dynamics? And the yellow is fewer disagreements among team members. All right, almost everybody got that one. Increased medication error. So basically the opposite of the last question. Somebody got 14 correct answers in a row. All right, let's talk about therapeutic communication. And you'll want to use this starting in your clinicals with your patients. It's an interactive process between the patient or the nurse and the patient, or pretty much anybody that you're dealing with. A therapeutic relationship is a caring relationship between the nurse and the patient that is based on mutual trust and respect, sensitivity, and nurturing. Therapeutic communication helps the patient understand their condition and encourages emotional expression. It's rooted in acceptance of the patient's viewpoints, kind of leaving our viewpoints to the side. Non-therapeutic communication is what we don't want to practice, creates barriers to open communication, like sharing our own personal information to the patient, irrelevant questions, false reassurance. That's a big one. Key components, active listening, and we're going to go into that a little more detail. So paying attention to verbal and nonverbal cues, clarifying and summarizing, ensuring mutual understanding, and providing some empathy, so understanding the patient's feelings without inserting personal judgment. Quiz time. A patient says, "I'm scared about my future." What is the most therapeutic response? And the yellow is, you should stay positive. So tell me more about what worries you. Good. And while let's focus on good things seems correct, tell me more about what worries you is even better answer. Heather's still in second place. Okay. The patient looks away and is silent. How should the nurse respond? And the yellow is, let me know when you're ready to talk. So this is an interesting one. So it's okay to be silent for now. Is probably the most appropriate response. However, most of you picked, let me know when you're ready to talk. I would almost accept either one, but telling the patient it's okay to be silent is even better. That does. It brings Ashley up. Okay. Empathizing. Basically, it's about the nurse envisioning the patient's experience without taking it personal. Incorporation, the nurse prioritizes the patient's feelings over her or his own personal bias. Reverberation, nurse fully absorbs but maintains objectivity. And detachment, the nurse withdraws emotionally to offer meaningful feedback. So we step back a little bit and think about what the patient's saying or feeling, and then provide that feedback. Terminally ill patient says, "No one understands what I'm going through. What is the best response to demo empathy?" And the yellow is, "Let's talk about your care plan." All right, so almost everybody got that one. Good. I can't imagine how hard this is for you. All right, Heather's back on the top. Okay. The patient begins to cry. What should the nurse do? And I think this is a pretty valid one. The yellow is say, "Please calm down." That's probably never a good choice. Good. We've got offer tissues and remain silent. And I've dealt with a lot of patients that cried and did the same thing. Let's see, okay. Active listening. So active listening is important for us to learn with our patients. So we're listening with all senses, not just our ears. So what we see on their expressions, and paying attention to nonverbal cues, avoiding interruptions and quick reactions. So we want to pause before we say anything. Some key blocks are rehearsing. So rehearsing what you're going to say based on what the patient says, assuming, judging, or filtering. So those are blocks. A patient recovering from surgery shares concerns about pain management. How does the nurse show active listening? And the yellow is check the phone during pauses. All right, so almost all of us got that one. So some said repeat exactly what it was said. And that's another term that we're going to go over here pretty quick. But the more right answer is lean forward and maintain eye contact. Yep. And the patient asked the nurse, or asked if the nurse has experienced surgery. What should the nurse respond? Or how should the nurse respond? The yellow is, why did you ask that question? It sounds like you need reassurance. And yeah, the second one, probably don't want to mention that too much, but I mean, in some cases it sounds plausible. But saying it sounds like you need reassurance, or doing that in some other words, would be appropriate. All right, Heather lost her lead. All right, physical attending. So working with nonverbal cues, maintaining an open posture. So not having your hands folded like that or looking away. Lean slightly forward and maintain eye contact. Consider cultural norms. Sit or stand at the patient's level. Nurse Sally is talking to a patient in the ICU. What body position shows physical attending? And the yellow is sitting at the patient's eye level. Right. Everybody got that one right. Yes. Sitting at the patient's eye level. Good. Let's see what that does with the board. Okay. Which action can interfere with physical attending? And the yellow is taking notes without explanation. And remember, it says interfere with. All right, good. Taking notes without explanation. So when you're taking notes in front of a patient, just let them know the basics of what you're writing down. Right. And Gordon Ramsay is back with answer streak of 3. Okay. Therapeutic techniques. There are a few things that we want to do. Using silence, so sitting quietly and waiting for the patient to express their feelings. Open-ended questions, that's important. Tell me how you're feeling today. And that opens them up to give more information. Providing general leads, and then what happened? Sharing observations. You seem anxious today. We don't want to make an assumption, but that's why we use the word seem. Reflecting, what do you think you should do? Because we don't want to give advice until we ask this. We want to see what their thoughts are on that. And summarizing, we talked about this, and this. Reflecting content and feeling versus feelings. So reflecting content refers to what the patient said, and that looks a little messed up. Example would be, you're worried about managing at home alone. Okay. Reflecting feelings, verbalizing implied feelings. Example would be, it sounds like you're feeling frustrated about your recovery process. The patient says, I am tired of being in pain all the time. How should the nurse reflect content of the patient's statement? And the yellow is, have you tried resting more? Alrighty. So you're tired of dealing with the pain. So we're reflecting the content of what the patient said. And all right, Chloe's on the board. The patient adds, I feel hopeless. How should the nurse reflect the feelings? And the yellow is, what do you mean by hopeless or hopelessness or hopeless? Yeah. See if I can read. You're feeling overwhelmed and defeated. We got 8. Although this might be appropriate. Why do you feel hopeless? But we're reflecting the feeling. You're feeling overwhelmed and defeated. So the key word would be the reflecting the feeling. Let's see. Puts Heather back on the top. Okay. Overcoming barriers in communication. This is kind of important. So interruptions, allow the patient to finish speaking. So sometimes, and I've noticed I've done this in the past, not with patients, but with others, I would just kind of jump right in without them finishing their thoughts. And then I learned how to manage that. Judgment, avoid inserting personal opinions. Assuming, clarify rather than guessing. And filtering, hear all aspects of the message. An example would be, I want to make sure I understand. Can you explain that again? What should the nurse use to overcome the language barrier if the patient speaks a different language? And the yellow is provide printed materials in English. All right, almost everybody got that one, good. The one person provide printed materials in English. Probably don't want to do that with somebody that doesn't speak English, but okay, guess. Use interpreter to explain post-op care. And I think there's an Oregon law about interpreters. I've used Google Translate once with a patient in the ICU, well, patient's family, and it worked well, but by law, I should have had a professional interpreter with that patient. Not that I got in trouble because nobody found out, but then you'd probably maybe sign up to be an interpreter. Yeah. Right. Let's see what we're doing on time. Okay. During the discussion, the TV is loud. What should the nurse do? And the yellow is finish quickly to avoid distractions. Ignore it and continue speaking. All right, so pause and turn off the TV. Good. Let's see where we're at here. Okay, so far so good. Angel is making a comeback. Therapeutic communication and action. So these might be helpful. Patient says, I'm scared, I'll never get out of the hospital. And the nurse can say, using empathy and active listening, it sounds like you're really worried about your recovery. Let's talk about the process or the progress you've made so far. Patient, I don't know how I'll manage this new diagnosis. Nurse providing general leads. Tell me more about what worries you. Patient, no one understands what I'm going through. The nurse reflects this. It feels like you're alone in this situation. Patient, I can't believe I lost my job. What am I going to do now? The nurse, using open-ended question. What are some thoughts or options you've considered? And the nurse, patient, I'm so angry, my body, or at my body for failing me. The nurse shares observations. I can see how the situation is incredibly frustrating to you. Therapeutic relationships, they're patient focused. So we want to seek trust and understanding between the patient and the nurse. Good practice would be what concerns you the most about your recovery. Poor practice would be don't worry, you'll be fine. And respect. Consider ethical background cultural practices. Good practice would be the nurse considers the patient's cultural preferences by asking about dietitian or dietary restrictions involving family members in this decisions. Poor practice would be ignoring the patient's request for a spiritual advisor because it seems unimportant. Privacy and confidentiality. That looks a little messed up. And the R should have been down there. Respecting patient modesty, privacy, and confidentiality. Good practice. Conducting a discussion about treatment in a private room with the door closed. Poor practice. Discussing sensitive patient details loudly in a shared area. Patient well-being, centering on the patient's well-being. A good practice. The nurse checks in. How are you managing your pain today to prioritize comfort and well-being? Poor practice is overlooking the patient's discomfort because of a busy workload. Mutual trust and acceptance, fostering mutual trust and respect and acceptance. Good practice is build rapport by acknowledging progress. I can see you've been working hard in therapy, keep it up. Poor practice would be showing frustration with the patient's slow recovery, which breaks trust. Some phases, and I think we're going to have a number of questions after this. Pre-interaction phase, gathering initial patient information and addressing any nurse anxiety. Introductory phase, this is where we establish trust and help the patient feel safe. Working phase, identifying problems and treatment plans. Empathy, respect, genuineness. Then the termination phase, concluding the relationship, possibly through transition or follow-up support. Quiz time. The nurse is starting an initial assessment on the patient. Which phase of the relationship is the nurse establishing trust? And the yellow is termination phase. All right, good. Orientation phase. So we want to establish that trust and rapport very quickly. Right. During discharge, what should the nurse focus on? And the yellow is identifying new problems. Good. Summarizing patient progress. Good. And that's where the patient discharge information comes in handy. And we want to build rapport as quickly as possible. All right. And developing a therapeutic relationship. And we'll just kind of go over this briefly. Be genuine and credible. Promote trust and being consistent. Be honest. Maintain honesty about limitations and set appropriate boundaries. Help identify feelings. And I'll just read the top ones. Cultural sensitivity. That's kind of a big one. Maintain confidentiality. Know the roles and limitations. Like if a patient is newly diagnosed with something and they don't know it yet, and the provider hasn't talked to them, you don't want to open up that yet. And use ingenuity. All right. Any questions on that before we go to patient consumer education? Looks like we have just enough time to finish this one. Yeah, I think we're good on time. A teaching environment. There are a lot of different teaching environments, acute care hospitals, physical practices and clinics, urgent care centers, extended care facilities, community settings like schools, libraries, community health resources. teaching individual patients. So setting goals for improving the patient and family health. Teaching process versus nursing process. So the teaching process collects data, analyzes patients' learning strengths and deficits, makes educational diagnosis, prepares teaching plan, implements the teaching plan and evaluates, and we're going to go over that in a little more detail. The nursing process, collecting data, making nursing diagnosis, plan for nursing goals, desired outcomes, selecting interventions, implementing the nursing strategies, and evaluating patient outcomes, and then changing the care plan as needed. One-on-one teaching, that's where most of it happens. It occurs during direct patient care. Preparation for teaching, or patient teaching, and teaching in the community. A nurse is educating the patient in the hospital room about med adherence. What is the advantage of teaching in a one-to-one setting? Prevent the patient from asking questions is the yellow. Good, everybody got that one. Focuses solely on patients' learning needs, because we don't want to teach them something that's not pertinent to what's going on with them. All right, and Heather's still in the lead. During community health teaching, what should the nurse prioritize? And the yellow is using only written resources. Yeah, that's kind of a confusing one. So cultural relevance of the information. All right, developing a teaching plan. So we want to assess what the patient's needs are. Like I said, we don't want to overteach something that they don't need. Identify knowledge gaps in medications, treatments, wound care, anything like that. Consider the patient's literacy level and cultural factors. So we want to talk at their level. Set learning goals, define measurable and achievable objectives. Prioritize key topics to cover medication management, self-care. And it's a lot about preventing readmissions to the hospital. Select teaching strategies. Visual aids, demonstrations, discussions. An example would be to show video on insulin injection technique, followed by hands-on practice with a demo kit. Incorporating technology such as videos and online tools when appropriate. Engaging the patient, that's the important part. Encourage active participation through questioning and discussion. And adjust teaching styles to the patient's preferred learning method. So that's when we assess, we want to learn how they learn the best. Evaluating learning using the teach back method, that's going to be important to confirm that they understand. An example would be ask the patient to explain medication schedule back to you in their own words. And you'll be able to find out whether they actually understand what you taught them or not. Assess outcomes through observation or follow-up questions. What should the nurse identify first when developing a teaching plan for a newly diagnosed diabetic patient? And the yellow is the time available for teaching. All right, the patient's learning needs. That's the most important. Dietary preferences, probably later in the teaching. All right. 10 minutes left. Which of the following should be included in the teaching plan? And the yellow is the nurse's preferred communication style. Good, almost everybody got learning objectives and evaluation steps. Let's see where we're at now. All right, Heather's still ahead. Identify learning needs. So assess the patient's understanding of their condition. It could be very minimal to they know quite a bit. Identify the knowledge gaps, and we can tailor our education based on that. Consider literacy level, cultural factors, and how they like to learn the best. Evaluate readiness to learn and their emotional state. What should the nurse assess to identify the patient's learning needs if the patient doesn't understand how to check blood sugar? The yellow is availability of teaching supplies. Good. The patient's prior knowledge and health literacy. All right. Lupita is back in the game. So establishing a treatment plan. Set clear, measurable, and achievable objectives. Prioritize key content based on the patient's needs. Develop a timeline for teaching sessions. Collaborate with patients and families or family members to ensure relevance. One goal would be patient will demonstrate proper use of inhaler by the end of the session. What is the key step when establishing a patient plan or a teaching plan when teaching a patient about how low sodium meal prep? Yeah, almost didn't make sense. The yellow is avoiding patient input during planning. Good. Collaborate with the patient on their goals. How should the nurse prioritize information during the first session? And the yellow is focus only on dietary restrictions. All right, almost everybody got that one. Address the most critical learning goals first. Good. And we want to do that because some patients could get bored with their education. Implementing a teaching plan. Use appropriate teaching methods to the individual, visual aids, demonstration, discussion, written materials. Incorporate technology like videos or online resources. Engage patients actively through questions and discussion. And adjust teaching strategies to match the patient's preferred learning method. We might be able to get through this. During the teaching session, RN notices the patient is distracted. How should the nurse respond to improve engagement? And the yellow is ignore the distractions and continue. All right, everybody got that one right. Ask questions and adjust the pace of teaching. What is the best approach to implementing teaching? And the yellow is tailor the teaching to patients' readiness to learn. Good. Tailor the patient's teaching to readiness to learn. So if they're not really ready, we're kind of wasting our time and their time. All right, Heather's still way up. Evaluation. So we have probably about 2 more slides. So we want to evaluate the teaching and learning that we're doing. Use the teach back method to confirm understanding. Can you explain back to me how you'll take your medication? Assess learning outcomes through observation and follow-up questions. Identify areas that need reinforced or further teaching and document the teaching efforts. The RN reviews the patient's ability to perform wound care after teaching. How will the RN evaluate the patient understanding? And the yellow is observe the patient's wound care demonstration. All right. Observe the patient's wound care demonstration. Good. Because how are we going to know if they can perform that task if we don't see that? Right. What should the nurse do if the patient's demonstration is incorrect? And the yellow is ask another family member to teach. All right, so almost everybody got that one right. Good. And then I think this might be the last slide. Focus on diversity and culture. Generally, it's said that immigrants usually have the lower health literacy. Not all the time, but generally. Public initiatives intended to improve health literacy, totally misspelled that one wrong, do not always reach immigrant groups. Helpful are informational pictograms and signs translated into multi-languages, using cultural mediators that understand the particular culture, improve health literacy and quality of care for immigrants. And I think that's it. All right, so BG's third, Hannah is second, and that's gotta be Heather, I bet. Yay, good. All right, any questions? And between me lecturing at the beginning and this, what do you guys prefer? Yeah, I think I do too. So probably Taylor next week's. There's a lot of slides for the respiratory and cardiac. So I'm going to look to see how best to deliver that to you without being extremely boring. Look at your study guide that I posted this morning. That's for this week and next week. Next week's going to be relatively extensive. I think it's on respiratory and cardiac alterations. And we'll do something similar to this, whether it's part way through or a good amount of it, undecided. So thanks for coming. Let's do this again next week. And enjoy, I think there's a 3-day weekend. Have fun. Try not to study too much. Or maybe study too much. Let's see. All right. Thanks for joining us, Curry. We will see you soon.
Thank you.
Thank you.
Let's see.